So I think we'll kick away, and we will just welcome quietly anybody else in that sneaks into the call as we go along. They're very welcome, so that's fine. And we're recording from now, so that's great. So you'll have an opportunity, obviously, to see back or to pass on the content of today's community of practice to colleagues. So I'm really excited about today because we've got Will and Alex here, who I'll introduce in a sec. So my name is Karen Kirk. For anyone that I haven't met. Usually Ashley Eaton delivers our communities of practice and has done a massive amount of work to sort of bring the community together and continue to spread the good work. Ashley's left the organisation now. She's gone on to bigger and better things. So you're stuck with me, but we're just as committed to continue in this work. And for those of you that have been with us since the start of the journey, the community of practice was born out of a big conference that we did. I feel like I want to say last year. It feels like the year before, but I think it was November last year, where we pulled together and worked really hard to get some brilliant people in the room over here in Carlisle to think about weight management and everything associated with that. And Will will give us an update in a minute around some of the work that's happening from a system point of view. But we're thrilled that you're still with us. We're still committed to bringing together this community of practice on a regular basis. So please do tell your friends, tell your mates. Just as a quick recap to let you know, and I'll send these slides out to you afterwards for those of you that came last time. And to remind us that it was Dr. Susanna Mills that was with us last time, and with the subject around severe mental illness. And that recording, all the recordings go onto YouTube, so the link is there if you missed it or if you want to send that on to anybody else. So today I'm going to hand over to Will in just a second to give us an update on the system work that is ongoing, and then we've got Alex with us, which is absolutely brilliant. And keep me right on this, Alex. I'm going to try and introduce you in the most accurate and best possible way. So Alex is with us. She's got over 10 years of experience as a researcher at TUV, working across adult mental health, learning disabilities and older adult services. So this research is going to be really exciting, and I think it's coming to an end now. So this is an opportunity for us to listen, sort of understand the learning, but also say, so what? So what does that mean for us in our practice, and what can we do actually as a system moving forward? So we'll hand over to Alex in a second as well. So all that's your presentation, so I'll bring that one back down and we'll hand over to you in a sec. So I would love to hand over to you, Will. Are you ready?
I am. Thank you very much,
Brilliant.
Karen.
Thanks,
I will
Will.
just do my slides. I won't labour the point on too much. I think if you've been previously, you'll have seen them, but just a bit of update on some of the things that are going on. So I'll just put on presentation mode. So for those of you who don't know me, my name is Will Smith. I'm the Healthy Weight Treatment Obesity Strategic Manager for the North East North Cumbria, and I'm blessed to have a clinical lead, Arit Chelvan Vijayaramam. He's a diabetologist and endocrinologist and been running a specialist weight management service in South Tees for the past 15 years. So very, very, very lucky to have him and been instrumental in a lot of the work that's gone forwards with this work stream. So just dead quickly, our work is kind of underpinned by 4 strategic themes and 2 enablers. So key things that we're working on is a whole system approach, advocacy around the food environment, service provision in terms of what's going on out and about in the community, and the work that we're doing around supporting the current and future workforce as well, both in like health and social care as well. The underpinning side of it about the comms and engagement and data intelligence. I'm obsessed with data intelligence. We've got loads in terms of stuff that we're doing and how we're doing this and the approach that we're taking. So just a little bit of an update. We're developing an ICB-wide healthy weight declaration. We've held a number of stakeholder events across the whole of North East North Cumbria. And there's a report and recommendations getting pulled together. And from that is going to be suggested strategic actions to help us implement our healthy weight declaration, and that looks at how we could do it within the ICB, how we could get out and about and across our organisations such as primary care, secondary care, anchor institutions, all the mechanisms such as healthy food policies, healthy vending policies, promote physical activity, reducing weight stigma, all those kind of things. There's lots that would go underneath that. So thing two, advocacy in the food environment. There was a conference we did on the commercial determinants of health around kind of the tactics that the private industry use. And it got people quite animated. So that was one of the things we wanted to include as part of our strategic approach. So we have out to tender at the moment, and I'm going to be scoring it next week for an organisation to do the insight work with the public around what do they see about the commercial determinants in the food environment. Do they think it's a thing? Are they actually on board with it? You know, would they want healthier food options? Would they want changes to advertising policy? Would they want things to change? Do they think that the commercial determinants is a thing? So we all believe in it, but we've got to obviously make sure that the public are on board with us and get their insight. And again, what that would do is help to connect very heavily to theme one in terms of how our approach would work and the kind of messaging that we would use as well. So service provision, one of the key things you probably have to be not reading any newspapers or looking at any social media to not taken notice about that tirzepatide was to be made available to the general public via primary care and secondary care, and it was a huge launch. So the interim commissioning guidance kicked in, and that was that basically NHSE, on the basis of what the NICE recommendations was, that under that eligibility criteria, over 3.4 million people would have been eligible across the whole of the country. So what they did was that they've only done it twice before, that they're putting a funding variation to do a staged approach to tirzepatide as the obesity medication. And what that meant was that they did a cohort approach of those who most at need would get it first, and that would be phased in over a kind of a 3 cohort period. And by the after that's been evaluated, then they would look to open up further, and the access would be available to everyone by year 12. So we've rolled out our options within primary care. So what we've got is 266 practices out of I think it's about 315 who signed up to a locally enhanced service to deliver prescribing of tirzepatide in primary care. And what's that resulted in so far? We've had 895 prior approval tickets processed, and those are people will be receiving medication. And then linked to that, they've got to be referred to the Behavioural Support for Obesity Programme, which is the wraparound care, which is part of the guidance and the NICE TA. So we've got 692 referrals to that. There's a little bit of a lag in between the two, and that's a lesson learned for the next specification that we'll implement, is that we do referral to the BSOP first prior to then getting the prescription, to make sure that they appreciate you've got to do both, can't do one or the other. For areas that don't have haven't signed up to the LES, is we're looking to use the right to choose pathway. And again, if you just kind of scour the internet or like being in your practice, you'll have seen adverts floating about from private companies saying that you can get access to the obesity medication, access to services, and you just have to ask for it. It was mandated by a slight change in legislation by NHSE in terms of developing right to choose pathways to support patients. In tier 3, we've implemented the prescribing, taking a little bit longer than we'd hoped to, just in terms of some of the red tape and getting the right staff in place. But so far, 75 patients are receiving medication, with 150 booked into up-and-coming clinics, and that number will quickly snowball, and we'll be getting up to the big numbers that are in primary care as well. That's just a little bit of an overview of what the behavioural support for obesity programme looks like. Essentially, it's got kind of three bits to it in terms of for the patient choice. You can do a face-to-face, which is similar to the National Diabetes Prevention Programme, or there's the tailored remote, which is very, very specific to the tirzepatide and the prescribing programme, and that's kind of done by teams, and they get lots of support, and it's over a sort of a 9-month period as well. Or patients who want to, they can opt to the digital service, which is app-based with support from kind of health coaches and dietitians as well, and that lasts for 9 weeks as well. We're getting more and more feedback about what is working, what isn't working well, and we're working with the providers to make sure that people are informed and know exactly what they're getting into and how it works as well. So we're adding that, and information from that we will add to our training provider as well, training platform. A little bit digital weight management and ongoing programs. That's for patients with a BMI of 30 with diabetes and or hypertension. To date, we're doing really, really well. Got about 50% of our designated uptake. So we've got about 3,500 referral with good representation from those from the most deprived wards as well. It's a good program, works well, and is part and parcel of the suite. It would be good if it had slightly less restrictions to it so we could get more patients through it, but it's a nationally determined program, but we continue to support it. So theme 4, which is workforce. So we have an online school of healthy weight and treating obesity services hosted by Boost, which is a fantastic platform. We launched in November 2024. We've got 591 people signed up to it, which is fantastic. We set ourselves a target of 500, so we've beat that. Over 1,500 modules are being completed. And we're getting a kind of average score of about 4 out of 5, and we continue to review that as well. We've done modules on treating insulin resistance through diet. We've done psychological factors as well, which is dead interesting. And we've got stuff coming around emotional and disordered eating, obesity and primary care challenges. And we've got one about weight maintenance as well, which is going to be really exciting. That's going to go on there as well. I would urge you again, if you get on there, have a nosy at it, take advantage of the great modules I've got going on. If as this community practice there's something that you feel that we're missing, please tell us and join us. And if you want to do a module, we've got funding to support people to help us develop more modules and get them on the pathway. And then the last one, and then I'm done. So there was a national scheme that was funded by Life Sciences and Eli Lilly as the drugs company to support obesity pathway innovation program, and it was 85 million across the whole country, and it had kind of 3 strands to it. And the one that we've applied for is to do a combined one around access to management services and actual pathways to support people. So it's the screening and getting people into services, but we're actually going to do services, and we've picked kind of 2 cohorts. It's anyone who's stuck on a waiting list, whether that be a tier 3 weight management waiting list or a waiting list for elective surgery as well. And then we're looking at a cohort as well of people at risk of economic inactivity linked to comorbidities linked to living with obesity as well. So we've submitted the bid. That closing date was middle of November, and we hope to find out if we've been successful at stage 1 in January, and then we have to do presentations and lots of feedback. Let's say it's Health Innovation North East Cumbria who've done that. And if we are successful, we'll be starting the project in February, and we're hoping to target all those people who are stuck on the waiting list. So it's quite big numbers. We're looking to target about sort of 15,000 to 20,000 patients. And that is me done, and happy to take any questions.
That's brilliant. Thanks, Will. While everybody else gathers their thoughts around questions or thoughts or just comments, and feel free to pop them into the chat as well, I've got a question that you might not be able to answer, so I don't want to put you on the spot. So you feel free to say, I've no clue. I'm really interested in culturally the weight loss drugs, and it was great that you gave the update in terms of us as a system, and you know, in terms of our prescribing pathway. But as I understand it, and I am a layperson in this, there is a huge exponential uptake privately of people accessing weight loss drugs, isn't there? And certainly I know abroad that you can get stuff over the counter even. So so there's all sorts of different possibilities there, be it legitimately or otherwise. And I'm wondering, on the face of it, that's a good thing, but unless people have the underpinning habits and all the rest of it. So I'm just wondering, is that being fed into our strategy in the Northeast and North Cumbria around what support looks like? Because it is gonna change the environment, isn't it, more and more as time goes on around what people do. Just wonder what your thoughts were.
It's very, very good question. It is. We're aware of that the private market is booming, and people want to access medication. It's been game changing in terms of what it can do to support people to lose weight. But if you read all the technology appraisals for all of the drugs that are currently on the market and the ones for the future one, they all recommend the underpinning lifestyle changes, because the evidence shows that when you stop taking them, that you do put the weight back on. You can reduce that by, in terms of if you've engaged and changed behavior as well, and really sort of looked at all of the kind of key factors around it and support it. one of the things that we are considering, and I think it's linked within the OPIT bid as well, is that people getting access to the wraparound support if they're taking the medication privately but didn't meet the criteria to get it on the NHS as well. So it's looking at those opportunities. If it is within the bid, we can do it within the bid. If not, that would be a legacy of the bid, is that there's that support program is embedded and we can offer it out to more people. And it's again, if you've kind of ever listened to me chat on about this kind of work, one of the things that I think is key is we've got specialist weight management services with some very, very well educated people and knowledgeable people and skilled people who understand all of kind of the scientific facts and the key things around living with obesity and what can be done about it. And my principle is that we should take that knowledge, package it up and get it out to people as early as possible, rather than wait until they get to the point where their health and quality of life is really, really deteriorated. We should get it out earlier and it'd be more of a preventative model. So that's my theory on, and that's one of the things I would hope to be part and parcel of the work that we're going to do if we were successful with the Obesity Pathway Innovation Programme funding.
Yeah, brilliant. Thank you. And sorry to put you on the spot with that one. And I just wanted to pick up on the Learning Academy work and obviously endorse what you've said there, Will, around the modules available. I know we have a subject matter expert as a program lead for that learning program. And, you know, what I would say is we are always open to new potential evidence-based learning that we might want to add to that program. So if there are, and for us technically, we're looking at different ways of being able to support that as part of the Learning Academy, be it through e-learning or different types of resources or live events. So if anyone ever has any thoughts or ideas around how you can contribute to learning, which supports the whole system, because our offer is open to citizens and people working in the health and care space in the North East and North Cumbria, then please do come forward to us and we'll put you in touch and we'll think that through. So just before we move on to Alex, thanks again, Will. Any questions from anyone? Any thoughts, any comments, any agreements, any disagreements? Anything goes here today. Okay. Great. So give us a thumbs up if you're all still there, because a lot of you are obviously got your cameras off, which is absolutely fine. But just as long as we know you're with us, that would be brilliant. Michael's still there with his real background, not virtual one. Great stuff. Thanks very much. So thanks, Will. Let's hand over to Alex. You're happy to share your own slides, aren't you? So I'll let you introduce yourself, because I'm sure you'll do it a lot better than I did.
Thanks, Karen. I'll just share my screen. So thank you everyone for joining today. It's lovely to see so many of you joined and interested in this topic just as much as we are. I feel like I've got some big boots to fill after that last presentation. So I'll try and do my best to give this credit where it's worth. So what we're going to be talking about is co-designing lean. So I'll talk about, oh, it's headed on to the next slide. If we go back. That's it, thank you. Which is talking about inclusive weight management for people with learning difficulties. So along the top is the logos of the organisations who are our co-op. So we applied for a Team Science Award and we have about 17 different co-ops. We've got some lovely co-ops on the chat today with us, but we've got clinical academics, we've got researchers, we've got people who have got lived experience, they're support workers. Up in the right hand corner, we've got 2 representations from theatre production groups. So there's Lawnmowers and Twisting Ducks. So we had 3 lived experience members from each of these organisations and their support workers. And we have one co-op who's a lived experience member who is fantastic in terms of research, very research active and involved at Camp Hill Village Trust. And he works very closely with Kate Sykes, who is our PPIE lead at Northumbria University. And we've got, most of these are kind of northeast, but we do have someone from down south as well. So we have got kind of a wide representation of organisations there. If you just pop to the next slide. So a little bit about me, not too much because the project is much more interesting than I am. But I'm a postdoctoral researcher. I specialise in integrated physical and mental health, so chronic pain and depression specifically. But I do have 10 years experience in adult mental health, learning disabilities, older adult services and nutritional neuroscience. One of the current projects that I'm focusing on, which is nearly finished, so we're finishing 31st of December, so we're nearly there. We're just kind of wrapping things up now. It's called the Lean Project. So I mentioned it was about co-designing inclusive weight management for people with learning difficulties. So that's what we're going to be talking about. So if that's not what you were expecting today, I won't take offence if you leave, but that's what we'll be going through. And I'm hoping today's going to be interactive. So the first part is just going to be me chatting about what the project is and specifically what are the learning points that we've got from the project. So there's not going to be kind of hard hitting outcomes from this in terms of findings, but there are a lot of learning points that we've had throughout the project which we can kind of implement into co-designing and team working together in collaboration. So we're going to be talking about that, and then there's going to be an interactive part where there's a couple of questions I'd like to get your feedback on. We'll come together to discuss that, and then we'll close for the day. So I hope that all sounds okay to everyone. If we just go to the next slide. Thanks, Karen. So why Lean and what was the challenge? So Lean stands for Learning, Energy, Activity, Nutrition Programme, and it was developed probably about 2013. It was a government funding programme that was run in Tees Esquire Valley's NHS Trust. And the programme was run really because we know that learning disabilities, people with learning disabilities often have health inequalities. They often have obesity or type 2 diabetes, cardiovascular problems, physical activity and weight management obviously being one of those. So the Lean programme was aimed specifically at people who wanted to manage their weight or have some weight loss. And it was over 8 to 10 sessions, and each session they would look at different aspects of physical health, and they would look at things like food labelling, they would look at movement a bit more, they would look at hidden sugars in things, or sugar potentially in alcohol and fruits, what sizes of food we should be eating, so what portion sizes, the Eat Well plate, and the first hour of a session would be about information given, and the last 30 minutes would be doing some sort of physical activity. And because it wasn't a research study, there was no hard measurable outcomes from that, but there was a positive lived experience feedback. Some people did lose weight. They set their own goals on how much weight they wanted to lose, and that was kind of a outcome, but there was nothing kind of looked at that. But they did like the programme, but they said it needed to be more fun and more engaging. So fast forward to, I think it was 2023, Jo Smith, who is a clinical academic at Teesside University, along with Emma Giles, who is the Professor of Integrated Physical and Mental Health at Teesside University, decided that this could be looked at again in terms of co-development and how would we work together as a team collaboratively to modernise a programme, make it more fun, make it more engaging. And Jo is specifically interested in how the arts and arts-based therapy and art-based activities, how can we incorporate these as well as digital technologies to make it more modernised and more fun and engaging for people. So that is the Lean programme in a nutshell. If you just want to pop onto the next slide. So our approach, so we had 6 creative workshops using the World Cafe approach, and I'll explain that in a little bit. And I mentioned a little bit before about the logos, but we did have lived experience members. We had practitioners, we had researchers, we've got clinicians, we've got dietitians, we've got specialists in digital and physical movement, and we had each session we would focus on a different thing. So the first session was kind of an introduction, and as part of the Team Science Award, we were granted a bit of money to look at training needs of people and what training people would want from this programme of work, really. The second one was looking at food, nutrition and diet, and then we looked at movement, general health and wellbeing, programme delivery in terms of thinking about digital and art-based health. And then the last one was thinking about the next step. So where we're going to take this, what are the things that we need to do, and thinking about the evidence from the previous sessions. What did we learn from that? Was it right? Was it something that you think would be a priority? And we got that feedback in the last session. So a World Cafe approach is a round table. It's like a round table exercise where you have participants all around the table and you have a host facilitator. So the host facilitator often has a topic guide, and they are there to facilitate the conversation, to make sure that people are having their equal say, and people have about 10, generally in a World Cafe approach, it's around 20 to 30 minutes. I will discuss about adaptations in our next slide, but it's typically around 20 to 30 minutes. And then what happens is the people on the table get up, they move to the next table, and the host feeds back what the last group is discussed, and then what's going to be discussed in this group, and then the evidence, it's basically adding new knowledge each time people go around each table. It's kind of a bit like speed dating, but for research. Yeah, if you just want to pop to the next slide. Thanks, Karen. So what did we find? So there was a couple of adaptations that we needed to do. So the first one was to move the hosts, not the members. So like I mentioned, in the World Cafe approach, in a kind of normal circumstance, you would have the members moving. In my experience, it was easier to move the host in terms of people who might have physical disabilities or find it difficult to move and have balance issues, coordination issues. So it was much easier to get the hosts to move, and that worked really well. And it's a little thing, and you think it doesn't make much difference, but actually when you're doing these practicality things and you've got a really short, limited time, it's these little things that really make a difference. And I think lived experience members really appreciated that we were taking into consideration that we are kind of adapting things for them. Each session was easy read documents. So we would have on the table their question, which with a picture and easy read guide, so that it facilitated people's conversations and they weren't hindered by the fact that it was using technical jargon. We also had jargon buzzers, which were, if you think about Britain's Got Talent, or I don't know if it's still running, but they have those buzzers and you press the buzzers and it alerts. So whenever anyone used any really hard terminology or jargon, as we call it, people would use those buzzers to let us know, and you could explain what you meant by those terms. Then we had a theme related starter question. So what we found really worked was having a theme starter. So not anything that we were collecting data from, but it was just really to get people to open up and start discussing things with one another and just getting people familiar with that type of questioning. So for example, the first one, I think for food, was something like, what's your favourite food? And it was really fascinating, actually, just to really get people's a little bit of personal background about someone, really, not kind of all nitty-gritty, straight down to research stuff. So it was really facilitated that kind of rapport building with one another. And the easy read summaries after the workshops, each workshop, once I collected the data, analysed the data, and then before the next workshop, I would send out an easy read summary of what we found, just to help reinforce learning of what we learned from that. Yeah, next slide. So what were the challenges? There was lots of challenges and lots of lessons learned. Like any programme of work, you will find that there are challenges. So one of the first things was we did try to do a remote or hybrid model, only for one individual who was often mentioned down south. So the sessions were very close together, so they were about 4 weeks apart. So I'll mention that a little bit in a little bit, but that was a complexity in itself. So we facilitated kind of a hybrid model, but what actually people said from being in the group was that they felt the person was less inclusive. They didn't get that same kind of rapport building as face-to-face, and I think that just really highlights the necessity to, when we're doing these types of core development, co-design things that actually we really do need to be face to face, and you gain a lot from being in the same room with one another. And so that was challenging, as well as the technical issues of having 2 laptops and making sure that there was Wi-Fi and one worked and one was on mute while people were speaking, just all those technical things. I think it really diverted attention away from actually just us being together talking as a group. So if I was to do it again, it probably would just be all kind of face-to-face stuff. Organising participants was complex, so organising 23 people to attend 6 different workshops 4 weeks apart one another, just the inherent difficulties of making sure everyone's got parking, we've got a room that facilitates this type of work, so making sure there was round tables, that the space was big enough. If you have too small of a space, what we found was the noise can really affect someone with sensitivity issues in terms of noise. So really having a large room where people can move around freely and it's not as loud really helps. The easy read documents require more time and is resource heavy. So you would think that easy read documents, because there's less words, would be easier, but they're really not. So I think growing up, you're always kind of taught that don't leave any space, you want to write academically, and when you kind of need to strip all that back down and go back to basics, make sure it's really short sentences, bullet points where possible, highlighting keywords and explaining those, pictures, and making sure that you've got pictures to describe the words that you've got is really important as well. We've done a lot of core development work with our PPI member from Camp Hill Village, who helped us design all the easy read summaries too. They were quite long, which is a challenge when you're getting so many findings, but yeah, you think it's easy, and it is definitely a skill you have to learn to do easy read summaries. Photo symbol is perfect. That's where all the pictures are taken from today. Photo symbol is really good for demonstrating that. Attention spans vary and require shorter focused activities. So essentially we had 2 hours, but that really, you think 2 hours is a long time, and it really isn't. Once you start getting to talking to one another, you spend the first half an hour discussing what you're going to be doing, you've had a cup of tea, you've had a chat on what you did at the weekend. By the time you actually get into the nitty-gritty part of having the discussions, you've generally only got an hour. Like I said, the World Cafe approach typically is around 20 to 30 minutes, but we really found that actually 10 to 15 is maximum for round before you're really starting to get people to disengage. So you could maybe do 2 rounds of 10 minutes each before you need a break. So trying to factor in lunch, breaks, chatting time, socialisation, which is really important because you really want to get that rapport so that you kind of get people familiar with each other so they feel comfortable sharing sensitive information. Weight can be a sensitive topic, can be quite triggering topic for some people. So making sure that you've kind of got built all of that into the time. So really, if you think you need 2 hours, double that time, and that's probably about the right length of time that you need. Instructions need to be repeated quite often, and just making sure that it's clear again in terms of it's easy read, concise, you're not using loads of jargon, and I've mentioned the other ones. Yeah, topic guide, creating the topic guides in such a short time frame is quite difficult, but we had expert advice from our co-ops on those, which I'm appreciative of. So yeah, there was lots of challenges and lots of lessons learned to take forward. Yeah, if you want to go to the next one, Karen. So what did we actually learn from the 6 workshops? So I've just got a few quotes there from our group, so our lean team as we call it. So we've got people did find it friendly and supportive, engaging. People liked the fact that we got so many people, different roles, all in one room. It was kind of a good size. I think we had most of the time we had about 23 members. And like I say, everyone brought their own experience, their own professional background, and that really did spark off some rich discussions in terms of the topics that we were going through, and it was very much a collaborative effort. There wasn't really anybody over and above anyone else. It was just a really collaborative discussion, really. And there's a couple of key themes that emerged across the entire 6 workshops. So we've got personalised learning and support matters. So we know that people really need it to be personalised to them. A generic programme typically isn't accessible for everyone. And just taking it back to that person-centred care. People wanted choice and flexibility, so they wanted taster sessions in activities, but they also wanted the choice to decide whether or not they would wanted to attend those. They wanted the choice to partake in some activities and not all activities, and just being flexible around people's needs and abilities. Teaching people practical real-world skills instead of instructions, so giving people the skills to maybe cook a meal by themselves, so do some cooking or do some attending the shops and seeing how you can shop better and more healthy. I think people said they would want that over a manualized kind of movement diary or something like that. Goal setting was important, and it is empowering for people to set their own goals and make sure that the small achievable goals. Integration of physical domain, so making sure that we're thinking about how our physical health affects our mental health and how our mental health can affect our movement. When we're not feeling great, we generally want to go for the high sugar, high fat food groups, and we also typically don't want to move as much. Like, I don't think anybody, when you're feeling a bit down, thinks, oh, I'm going to have a nice salad. It's generally, no, I'm going to eat that chocolate bar. So thinking about how we can integrate all of those health domains to make sure that people are being supported through those. And making sure, I just mentioned about the health domains, but one of those is the social element of it, and making sure that people have the social support and the social network to be able to help deal with physical and mental health. Accessibility and inclusivity are important, so making sure that whatever sessions or movement you offer are accessible. Not everybody have the funds to go to a gym every month or have a bus pass to get somewhere or have the means to get to some of these places that we might suggest people go to. So making sure that they are accessible and that they're low cost or free options, and making sure that they're fun and engaging. So people mentioned that using arts and drama would be helpful in making it fun and more creative, but only when it's appropriate. Not all topics are aligned or appropriate to use with art and drama, and it should be delivered by somebody who is specialised within that area. And optional technology. So some people really like the idea of smartwatches. I know I've got one on, but I kind of just generally have it on for the time. But some people really religiously use it for the steps, and some people find that really helpful and it gets you to move a bit more. But some people feel like they're let down if they don't do enough steps in the day. So really making that optional, and it's going back to that person-centered approach and making sure that the program's personalised for that person. And carers' involvement, so making sure that whatever people learn through the program, they can then feed that back to the carer. So whether or not they have the carer in the sessions with them, or whether or not we run another program alongside that program so that they are getting the information in a different way, but they can help support the person who's going through the program, or whether or not it's just documentation that can be shared with carers or family and friends to support that person. But just having that option to make sure that whatever somebody learns within the program can be effectively supported outside of the program. Yeah, if you want to go to the next one. Thank you. So the next step's a core development phase to make sure that we can create some materials that are accessible and engaging to use. We can look at the structure of the sessions and how they're going to be tailored, and look at the format that really has sustainability to it. So we're going to have a look at collaborative design again. So we need to have collaborative design for materials and the structure of those documents, looking at feedback and iteration, so testing those out and getting people's feedback on, do you think this would work? Do you not think this would work? And then we've got the implementation plan. So thinking about kind of piloting the intervention and making sure that is sustainable and ready to deliver once we've done the pilot study. So yeah, next steps. So why is it important? So I mentioned a little bit in the first slide, so we need to address health inequalities for underserved communities. We know weight management and obesity is more prevalent and more susceptible for people with learning disabilities. We know physical inactivity is also quite high in learning disabilities, and we want to empower patients through co-design. One of the members, our members, I remember saying, you know, we want to lead on it. We don't want people to tell us what to do. We want to lead on the program. So thinking about kind of service-led things and peer-led support, and then looking at creating a replicable model in services. So there's still a little bit work to do, but it is important that we continue with this work. Yeah, next step. Yeah, so we're now come to the interactive component. So I just want to, in small groups, just have a little chat about some of the questions I've just populated here. So thinking about how can we learn to be more, how can lean be more engaging? So what can we do to make it more engaging for people? We have looked at arts-based arts-based activities and also digital formats, but what are your takes on being more engaging? Thinking about learning and motivation, what works best, and then the last one is how can we measure success effectively? So this is kind of coming down to thinking about what's meaningful. It's kind of two questions really, because what's clinically meaningful for the person who's going through the program versus a funder or research staff sometimes differs. So for a person to go through a program that's related to weight management, one of the things that they might be more clinically meaningful to them is to be able to effectively learn a skill that helps them cook better, or it might be learning a new activity that increases their movement, which can lead to weight loss. Whereas generally for us as research, we want hardcore outcomes of, yes, it definitively works, and this is why. And the Lean program did look at weight loss in terms of people being weighed after every session, but feedback is that people don't want to be weighed, and quite rightly, I don't like being weighed, so I try not to weigh myself, but that might not be meaningful. It is a weight management program, so we do need to think about how we can measure the success, but it might not be necessarily we're going to weigh everyone after every session if people really don't like that, and it disengages people from coming to the sessions if people know that they're going to have to be weighed. So it'd be really good to get your thoughts back on kind of that question as well.
Welcome back, everybody. Just counting you all back in. Please do keep your cameras on if you feel brave enough. I'm sure you've all washed your hair and look lovely. So I'm just making sure everybody's back. Are you with us, Maria?
Yes, I'm
Oh,
here.
great.
Yes.
Great that you're here. Unfortunately, Maria wasn't able to join a room, and then one of the rooms only had a couple of people in because some people had to leave. So I redistributed you. So I hope that didn't make you dizzy, and it made for a fruitful conversation. So what I want to do is just, because we're recording this as well, so this is brilliant, Alex. You'll have this sort of rich information to feed into sort of the project as you come to the final stages of it for now. And I suspect those three questions all overlapped a little bit. And in particular, that measuring success is a really interesting one, isn't it? Because to me, it strikes me that it's an intervention in itself. So whilst it might be around weight management and healthy lifestyle, it's, you know, there's so much more that could be got out of just having that interaction and getting those people together. So what I'd love to do, be brave, is, and you know, you don't have to stand on ceremony here, just tell us what rose to the surface in the conversations in each of the two groups. So we only had a couple of groups in the end. So so who'd, I don't want to pick on anybody because I can't remember who was in which groups, but who'd like to give some feedback from one of the groups? Let's just get a sense of the conversation and the stuff that seemed to be common around what struck you from Alex's presentation, and also what, you know, what you could take forward or what could be done.
In our group, we talked a lot about carer involvement and how important it is to have the carers and people involved and educated as well, but also helping with that engagement, like including bringing people to sessions and the importance of that.
Yeah, sounds really like it's really important. I don't know, Alex, where what consideration was given to that? Were the carers there as well?
We had support workers involved from the two therapy from the two drama representations, and one from Camp Hill Village. But that was one of the key things that was coming out from the workshops, was they would like somebody to help with the support, whether that be them in the sessions with them or whether or not that would be just kind of feeding back alongside the program, but really having that continuity really of what someone learned in the program, how can that then be translated into real world skills, real world transitions. So that's a really important consideration to have, but some people didn't want to have family or friends or carers actually in the program with them. And I think it's one of the key things that we were talking about in our group was actually it's so individualistic, like there's no one size fits all for each person, so it is very much has to be tailored to an individual for it to be effective for them or and meet the needs for them. So options and choice is core for this.
Yeah, great, thanks for responding to Sophie. So tell us a bit more. What else came up in the groups?
We spoke about like the Eat Well plate and how that's really complicated for people and even carers to it doesn't give that visual aspect of, you know, and would people benefit from sort of pictorial menus and portion sizes on plates to go away with after the group, and maybe bring back if they've tried anything new, but we educate, don't we, often on the Eat Well plate, and retaining that's really quite difficult. And we spoke that people might just focus on the foods they don't like on that plate rather than discussing what they do like and how that can be, you know, improved or swapped. Things like that we looked at.
Yeah, and that was definitely one of the things coming out from the groups actually, was that the Lived Well plate, in terms of kind of visually having real food on a plate in portion sizes, or like you say, using pictorial menus so people can see how much people should be eating, and portion sizes, thinking about it in actual physical, being able to hold how much I'm supposed to be eating, because even with the Live Well plate, it can be confusing of how much of one group, and I think having an awareness of what types of food as well have like hidden sugars. So we were talking about smoothies being healthy, but if you have you know 5 pints of it a day, it probably isn't very healthy for you. So it's not just about the food per se as well, but it's also about like the quantity and portion of it. So that's definitely important, because I think that it can be complex, the Live Well plate.
Good. What else? We've got time for a couple more thoughts. What did you get, Alex, from the group that you were in, that you were listening to?
We discussed a lot in terms of the individualistic part of it, so making sure that it's individual to the person, because we were talking about how, you know, even if you have two people who have got mild learning difficulties, their context and everything around that person can be vastly different. So the amount of support someone might have, the amount of physical difficulties or mental difficulties, all contribute, and it might not be. We talked about potentially having different, almost like a triage, and so you have like an assessment at the beginning to assess your needs, and then maybe being allocated to different types of groups. So maybe one that's a small group, maybe one that's like a large group. Some people really have issues with kind of the noise of having a large group. The feedback was actually that people like to have small groups, so that was one of the things. But yeah, trying to think about that, or whether or not we really just need to think about an individual program that's tailored specifically for individuals rather than thinking about a group. We didn't have many kind of findings in terms of, yes, this is what we're going to be doing, and like with this program throughout, we get more questions and we get answers to, but that's what it's all about, facilitating that conversation around this. So that's what our group kind of fed back. Is anybody else, Kaylee or Mike, do you want to feed back anything that we discussed in our group?
I guess just to add to that, I got not cut off, but we got moved back into the bigger rooms just as I was just as we were sort of thinking about that and access to different services, and I had started to have a think about, or one of the thoughts I had was about current services and the specialist weight management service that we have in South Tees, for example, and rather than recreating a whole new not a whole new approach, but rather than recreating something, is there an option of using some of the findings that you have to embed into current specialist weight management services, so that we're making those services more accessible for people with learning disabilities? Just a thought, just an idea, but yeah, it's definitely a really hard thing to do, isn't it? Because you're right, there isn't a one size fits all, and what's really important for one person is completely different to another person. So it's not an easy job.
Yeah, absolutely. And you know, again, going back to the evaluation piece, I think it's a real prime piece of work for what we would call, using management jargon now, we need the buzzer, for like a human learning systems approach to it, which is actually, oh well, we haven't got a KPI that says people must lose a percentage of body weight, or anything rigid like that. It's more about actually, well, we've got a theme and we've got a plan as to the types of things that we want to cover, but actually I can imagine that those knock-on effects of people coming feeling good about themselves in any way probably has a positive knock-on effect in terms of the rest of the sort of lifestyle stuff. So it's a tricky one, isn't it? You're trying to meet lots of people's needs, but actually in the intervention in itself will have an impact in some way, shape or form, and it's trying to measure that. So okay, so this is all recorded, Alex, and we've got obviously an opportunity if anybody wants to feed in afterwards. If you're feeling that you're more reflective and you want to feed in, I'm sure that Alex will be receptive to hearing any thoughts or ideas or critical feedback. So I'm going to hand back over to you, Alex, before we wrap up, because I want to give you an opportunity to sort of finish your piece. You do have one more slide. Do you want me to flash it up? I think it was a kind of thank you slide, but I'm happy to flash it up if you want me to.
Yeah, just for the contact details, because there's not just me involved. So
okay, good.
That's okay.
If I can find it. Good, here it is. Okay, Lee, have you got a question there?
Yeah, it was just Alex, you were saying about this project sort of finishing up and towards the end of this month. It was just to ask what happens next, and if there's anything that we can be doing like ourselves within our own services to continue this piece of work.
Yeah, so this piece of work will finish. The next steps, I mentioned a little bit before about it, but the next steps, we were hoping to be at a point where we had a definitive, this is what a program would look like. That's not been the case. It's kind of threw up more questions. So I think the next steps would be to build upon what we've learned, to try and come up with what a program would actually look like in terms of session content, materials, whether or not we need to do multiple groups, whether we need to tailor it individual to people's needs, go to other services, like you said. So in terms of going forwards, if you keep in contact, hopefully we'll kind of have co-ops for the next phase of it, with the intention to then kind of maybe get a programme grant after that to pilot the said intervention. But yeah, there's not really any hard evidence to take back for general practice at the moment. We are in the process of finishing up a scoping review. If you want to be involved in that, Kaylee is also in one of our co-ops, so if you want to be involved in the scoping review, just let me know, because my capacity is limited as we're kind of running down the study. But I can get in contact with you separately about that if you want to do some writing. That would be great. But yeah, we'll just keep in contact, and the next phases happily have you on as a co-op.
And you're part of this gang now, so anything you want to feed back into this group, or if you want to get the support or help from the group or test anything with the group, obviously you're very welcome back, or welcome to send anything back. We've got a community of practice page on the Boost website where we're really happy to house information or some evidence-based practice that is going to be helpful to other people. So however we can help, and Will Smith will support as well, who I know that you know.
Perfect. Thank you, Karen. So
and I will send the slides out as well, obviously.
Yeah. So just last slide, just to say thank you. Thank you for attending and sharing your thoughts and answering my questions that I had. I'm not by any means the lead on this, so there is me today who's been presenting, but Jo Smith, who's a clinical academic at Teesside University, you can get in contact with her if you're interested about hearing more or wanting to be part of the next steps. Contact either Jo or Emma, and I'm sure they'd really welcome any thoughts, opinions, or involvement in the next steps. Or you can contact me and we can just have a chat. But yeah, thank you very much for attending and sharing your thoughts and your opinions today.
Brilliant. Thank you so much. Now, if you've got the technical prowess to show your appreciation virtually like this, feel free. But I'm sure everyone's very appreciative of your time today. Thanks so much, Alex. It does mean a lot to us. And, like I say, genuinely, if we can stay connected to the work and its outcomes and the next steps and all of those sorts of things, let's feed them in. So that's absolutely brilliant. Thanks again. And obviously, if you want to be part of the community of practice, you can come to the next one. So, and we'll grow it that way. So I'm just going to wrap up, coming to the end of our time now. Thanks so much, everybody, for your time today. Really appreciate it. As we always say at the end of our sessions, I was just, rather than having to flash up the last slide, going to stick it into the chat there. Hopefully that will work. I'm not sure if the Padlet link will work, but I'll do it again. So we have got on our community of practice page the Padlet, which is a bit like a graffiti wall where you can contribute, you can connect, you can pop in there. Let me put it in a different way. There we go. Well, I don't know why that's come out so big, but that's fine. And you can link onto there and you can pop anything into there sort of regionally based around the work that you're doing, or if you want to connect with other people. But in particular, if you want to connect with us, if you can think of a piece of work that you or a colleague or someone would really value from sharing into the rest of the group, then please do let us know. We'll be looking to do another community of practice round about March. So thanks so much, everybody, again, and thanks to Alex and to Will. I think has popped off now. So and we'll speak to you again soon.
Thank you.
Thanks.